Similarly, I will try to speed up a little bit regarding enabled by eHealth. It will show that we are going to implement the interoperable electronic health record, and how we can improve the productivity, how can we improve the performance. So how the eHealth will be will be the enabler for us to improve these things, and how can we govern all these program. So these are the main, almost 22 initiatives that we started with. For example, if we came to the first one, which is the integrated comprehensive healthcare services, in which we are targeting to have a continuum of care across organizations. First of all, you will need, these are considered under the umbrella in the IT of care for patient. So it includes all the clinical automation applications, which is all like the HIS, primary healthcare solutions, whatever lab information systems for the regional regional laboratory in all 20, for example, regions, or if you have even many lab within one of the primary healthcare. So these are responsible for automating all these services. So all the projects that are included will be under these initiatives. And by the way, these, although they are maybe 4 or 5 project, but it's not project, it's 4 or 5 programs under one of these initiatives. And this program will require, if you implementing an HIS in 370, say 300 hospitals, it will be something very huge. That's why we put empirically here that we will send this project to the market over in the first 5 years, 6 years, but it's going to be implemented over 10 years or more. The other, for example, the preventive or the public health, and it's an initiative by itself, have multiple projects inside. We will see now the full roadmap, and so on. If we go to the other track, which is measure and collaborate, we call it, is the area where we would like to improve the service from the business side. So we need to measure, and that we put underneath all the project related to the standard. From the clinical coding reference technology till the messaging and everything. In addition to that, all the processes of the analysis that we will do afterward, and the other health services. Sorry. Okay, so the process that how we get or we choose or build the roadmap of these projects. Initially, we, as I mentioned before, that we get the benchmark and see the needs and the business strategy of the ministry, and then we came into a group of projects in which we did sort of a prioritization from these dimensions, from the business need, strategic alignment to the business, and stakeholder readiness, business economics, if this have a sort of an can be a sort of an income, and then we give weight for it, or the risk. And it's divided into 2 main dimensions by doing that exercise of scoring. The first one, which is the risk. Okay, it can be. It's not a pointer. So the risk, the lower one in the right side will be the highest, the lowest risk project, and to the left side is the highest in the risk. ما هو pointer هو أنا بستخدمه. هو أخده. So in the left side, to the upper side is the highest in the business need, and to the lower side is the lowest in the business need. So the project in the upper right corner are among the lowest in the risk and the highest in the business need. And so the first wave was the first on the upper right, and the second wave and the third wave afterward. How to do as a pointer? Okay, thank you. Thank you. Yeah, sorry. So this group was among the lowest in the risk and the highest in the business need. Of course, this is revised again based on some of the main directions. Like, we have a challenge here in the kingdom during Hajj time for the risk of the infectious disease. At the same time, we have some projects that need to be aligned because it have some prerequisite. They have to be aligned with each other. So that was the final roadmap. The first wave was this one. Second wave was this group of projects, and this was the third wave. So we came out with this roadmap that show all the projects, and some of them, as I mentioned, are programs. Like here, this one, an HIS, it's by itself, it's a huge program. This is primary healthcare. It's a huge program that will remain for more than 10 years as we expected. Okay. Now, generally, the overall view of how this how this implementation, going to be. We expect in the first 3 years that we will focus initially on the clinical automation for most of our, Ministry of Health facilities, primary health care centers, hospitals, and this. At the same time, in the other track, we will concentrate on the area related to development of the standards. And most of, the e-health programs across the world, most of the delay that happen on those areas are related to the areas of developing the standards or implementing the standards. So the standards and policy, whether, as I mentioned, clinical coding or the messaging itself, how it's supposed to be. In the third level, we work on the improving our capabilities, the skill development, and to build the data centers that are required to reach into the interoperable electronic health record. Most of the people, they hate the word of interoperability because it usually let you, okay. So, and we expected after these 3 years, we will start to have, after we are ready with the standards, to have an initial centralized interoperable electronic health record, in which this data will start to be exchanged across the wires or stored in a repository. We'll see now the conceptual architecture of how this will be we meant to be operated. At the same time, when we start to collect data, you can start to have a sort of quality assessment of the data that you are aggregating, and by time you will go more and more in that. Okay. During the strategy development, we came with so many principles. These principles usually, by time in the strategy, every year, sometimes you have a sort of a review. Sometimes the business, they change their priorities. So they give this project we want it early because we have this problem. So you receive some requests that you need sometimes to manipulate. This is not Quran. You can do some changes. But some of the principles that you place in there, usually it will sustain for a longer period. Some of these principles based on the best practice. For example, one of the principles is we try to be centralized whenever it's possible, and decentralize whenever it's necessary. That means, whatever solution that we can implement centrally and can operate centrally, that will be the best approach. But we will be decentralized. That means we will host the solution within the facility whenever it's necessary, whenever we have to do that, either due to the criticality of the business or due to other factors like unsteady connectivity or whatever. So if you would like to implement an HIS and you think, should I do it centralized or decentralized, then we will weight it based on the business need. Now, if this hospital serving, for example, a psychiatry hospital or a hospital that they don't have really a critical patient in ICU or some critical module that if they have a down in the connectivity for a short period of time, then it will be a risk for the patient, then you can do this centrally. Or if it's a very small hospital, or then otherwise you're going to have some caching in that local, or you have to have more than one link using more than one vendor or more than or different technology, so that you will sustain the connectivity to assure the enough availability to serve the patient and to avoid the risk. Similarly, one of the other principles, just an example, is that we would like to save, the investment that we are doing. Most of the time, you will hear that I need to have a quick wins in the beginning, so that you will have your management. They will be happy that you are achieving things. Things are being done. We are having the patient become happy. They are receiving messages of their appointments. Things that you can do it as a quick win, that can give you a support. On the other hand, whatever solutions we will try to do as a quick win, we should put in our consideration that the investment we are doing here, it should be linked to what we are going to build when we reach the final picture. So we don't want to say, okay, this is up for 3 years and then I will cancel this project because I am going to do the other project and it will be removed. So these are principles. When we put it, whatever solutions we think about, we'll try to expose it to these principles to be sure that really we are committed to the main principle that we decide. Okay, this is what's called the conceptual architecture of how we expect. What's the overall picture of how our exchange engine and how the facilities will be exchanging the data across the enterprise health bus. In the left side, this one, very short, representing all the different solutions, whether it's a solution within the Ministry of Health or if it's a solution within the data center, I mean a centralized solution, or if it's in a facility in a private sector, for example, an HIS in a private sector. These all facilities going to exchange using the standard through the enterprise health bus. Why we go into this approach? So reaching into the interoperability using this, this concept that this is, we are, one of the countries that we have to do that. If we have, for example, some of the countries maybe they have, as a whole, only maybe 30 hospitals. These countries, they can go into one solution and that's it. And they can control the situation, even in the private sector. But in our situation here, Ministry of Health doesn't own all hospitals. And other organizations, they might serve different level of services in which they require more advanced solutions in some of their facilities. On the other hand, we have the private sectors that we cannot control which solution they will use. So we cannot expect that having 2-3 solutions across the kingdom, which we are targeting in Ministry of Health plan for Ministry of Health facilities, we are not expecting that approach will help us to have an interoperable